Aortic dissection. Everything that you need for USMLE STEPS exams. Blood vessels are made of 3 layers, which are 1. The inner one called the intimal layer. 2. Middle medial layer, which contains smooth muscle. 3. Outer layer called the adventitia. Dissection occurs as high blood pressure creates tear in the intima and blood rapidly goes through it to accumulate between the intima and the media, and the shear forces caused by high blood pressure helps it to extend. Why is it important? The new false lumen, the created by the shear force, divide the true lumen so that the aorta appears divided by thin serpiginous line presented by the red and blue arrows, which represents the intimal layer of blood vessels. This sign called intimal flap. Aortic dissection is associated with hypertension, most important risk factor, bicuspid aortic valve, inherited connective tissue disorders, e.g., Marfan syndrome. All of these risk factors lead to medial cystic degeneration and facilitating the dissection to occur. They differ in the time at which they make it happen, as it occur early in life in bicuspid valve and connective tissue diseases due accelerated medial cystic degeneration. It present with retrosternal chest pain radiating to the back. In addition, symptoms related to extension of the dissection that you should be aware of. Modality of imaging you choose to confirm diagnosis depends on the patient hemodynamic status. 1. If he is hemodynamically stable, then CT angiography, also known as CT aortography, is the gold standard. However, chest X-ray can be done, and it typically shows mediastinal widening. 2. If the patient is hemodynamically unstable, then using transesophageal echocardiography is the most appropriate. Dissection can be classified using Stanford or DeBakey classification as either ascending aorta dissection or distal aorta dissection. The exact number or types as A or B are not a questions to test it on the USMLEs. Direction of the dissection extension. 1. Proximal extension, which is towards the heart. 2. Distal extension, which is towards the descending and abdominal aorta. Complications of extension. If the dissection extends to carotid arteries, the patient have additional symptoms including stroke and Horner's syndrome, which is caused by compression of the sympathetic plexus that innervates the eye and face, which is found traveling along the outside of carotid arteries. It can also extend proximally to involve aortic valve annulus, causing acute aortic regurgitation, and patient may develop acute decompensated heart failure. The coronary arteries involvement causes myocardial infarction, and if it reached the pericardium, it causes pleural effusion and cardiac tamponade and obstructive shock thereafter. Pleural cavity extension causes hemothorax. If dissection reaches renal arteries, mesenteric arteries and spinal arteries, this causes renal infarction, intestinal ischemia and lower limb ischemia, respectively. Now let's see all the possibilities in which the USMLEs could ask with regards to aortic dissection. We will use one scenario to test it all. Here is a 24-year-old man came to the emergency room due to retrosternal chest pain radiating to his back that started 30 minutes ago. He has a history of polysubstance use disorder. His BP is 180/110 in the left arm and 160/100 in the right arm, pulse 120 and RR20. Examination shows his pupils are dilated. First question. What is the most likely diagnosis? It's aortic dissection, probably due to cocaine intoxication. Second question. Why the BP in both arms not the same? It is not the same due external compression of the accumulating blood to upper extremity vessels.